today's lecture with me. We have the 10 objectives that are listed there. Those objectives go along with the ones that are attached to your concept guide. Have you all reviewed those? Do they look familiar? Is this your first time seeing them? Thank you for being honest. Okay, so these are the objectives. I'm not going to read over them, okay? Any questions on the objectives? So the first thing we're going to look at is a comparison between hospice and palliative care. Who can tell me the difference? This information can be found in your Med-Surg book, also on page 139. Anything in particular, when you look at that slide that stands out, what is the difference?
The prognosis for
testing. Prognosis for hospice care, lasting, you may have had a diagnosis, or you're doomed to only have at least 6 months to live or less. Okay? Treatment is curative treatment has stopped. I heard that. So let's look at it. Let's talk about hospice care. Who wants to read everything that's under that one for me or call it out? Thank you, LaToya.
hospice care. Patients have a prognosis of 6 months or less to live. You want me to do like
do all the hospice and then somebody else will do palliative.
Care is provided when curative treatment such as chemotherapy has been stopped. Care is provided in 60 and 90-day periods with an opportunity to continue its eligibility criteria are met practices. Ongoing care is provided by registered nurses, social workers, chaplains, and volunteers.
And Gregory, if you'll take palliative care for me.
Consultation provided that is concurrent with curative therapies or therapies that prolong life. Care is not limited by a specific time period. Care is in the form of a consultation visit by a primary health care provider with a recommendation. Follow-up visits may be provided.
So hopefully that'll give you a little clarity on the difference between the two. How many of you thought all of that fell under one? Did y'all know it was a difference between the two? I see some yeses, some no's. Okay, we're just going to touch up on these topics for a brief moment. Many healthcare providers view death as failure. Who can tell me why? Why would a doctor view death as failure? They try to save lives. They've done everything they could do for the individual, yet what? The individual may have passed. When the body is hypoxic and acidotic, and for example, if they're on something like the ventilator, or if they've had cardiac arrest or respiratory arrest occurs, when respiratory arrest occurs first, what's going to happen next? What follows respiratory arrest? The cardiac arrest. They go hand in hand. We're going to talk about the concept of comfort and end of life. Back in 1991, the U.S. Congress passed the PSDA, which stands for what? Patient Self-Care Determination Act. Is anybody familiar with that? What does it tell us, or what does it remind us? That these Americans have the right to what? Medical care if they become incapacitated. So what is incapacitated? Anyone who's under the age of what? 18, or if they're unable to provide the basic needs for themselves, they have a right to medical care. The American Nurses Association and the Hospice and Palliative Nurses Association, both of those support the nurse's role in taking care of the client who is having changes and end-of-life changes. We're going to touch up on some terms that we mentioned earlier in our legal and ethical concept. Advanced directives. Who can tell me what that is? Give me a refresher. Answer yes or no on that sheet. Okay, so you're asked when you come into the facility if you have an advanced directive, and the answer is yes, what you're going to do? Give them that document, okay? Anyone can complete these forms without legal consultation, okay? Do they vary from state to state? Yes, they do. Generally speaking, most have a section in which names a durable power of attorney for health care. What is a durable power of attorney for health care? Someone who can make those decisions for you when you are incapacitated. Okay, there's a durable power of attorney for one's finances. So you can have two types, one for your finances and one for your health care. But what are we referring to today for these patients? For health care. All right, often the decision-making ability for that person, to say you're cognizant, you must be able to receive information. That doesn't mean you have to be totally oriented. You must be able to evaluate, deliberate, and mentally manipulate information. And you must be able to communicate a treatment preference. That means you have the right to make these decisions or to make this informed decisions about your health care. The second part of an advance directive is called a what? Living will. What does a living will tell us? What extent you want the provider to go to save your life. This typically includes what? CPR, artificial ventilation, and artificial nutrition and hydration. All of that is part of the living will. There's a third type of advance directive. And what is that one called? DNR. And what does that mean? Do not resuscitate or do not attempt to resuscitate. And this must be signed by the physician or a other authorized primary health care provider. Which means if I code, what are you guys going to do? You're not going to do anything. It instructs that CPR not be attempted in the event of cardiac or respiratory arrest. So is everybody kind of familiar now with the terminology? It was kind of a refresher. Some states also have what is called a POLST. Who can tell me what a POLST is? Physician orders for life-sustaining treatment. What you want them to do is additional instructions, what they can do if you have a cardiac issue or a pulmonary issue. By law, all primary health care providers in the United States must initiate CPR when a person is not breathing or is pulseless unless they have a what? DNR order. Very good. Now we're going to jump back on to hospice and palliative care. Hospice care is considered to be the model for high quality, compassionate care for people facing life-limiting illnesses and injuries. Hospice uses a team-oriented approach, providing expert medical care, pain management, and emotional and spiritual support expressly tailored to the person's needs and wishes. And who is that team approach? Who all is included in that team? Very good. Palliative care has been proven to improve the quality of life during end of life. For example, like a terminal illness. Yet it often is provided too late. Often it may not be beneficial for the patient or the family because usually they're given that option far too late. So one thing that the health care is pushing is that you offer or provide palliative care much sooner, okay? Not waiting so late. Research has shown that the value of palliative care, if it's initiated earlier, provides more positive outcomes for the patient as well as their family. What do y'all think about that? If you're giving the information up front, you know what to do, you know you have these options. It provided better patient outcomes and better outcomes for the family. So, we're going to talk about patient-centered care of the older adult as well as those individuals across the lifespan. How many of you remember to bring your OB book today? Okay, we're going to jump in it for a brief moment a little later on. In the last 15 years, twice as many older adults died in hospice as in the hospital nursing home compared to within a previous decade. So what is that telling us? More people are opting in to take what? Hospice instead of dying where? In the hospital, in the nursing home, or at home. The goal of palliative care is to improve the quality of life for the patient as well as the family. What are y'all noticing that I'm saying? Who's included? The family. Do y'all remember us talking about that last week when we went over the concept overview? The family is a part of it. An interprofessional team, doctors, nurses, social workers, chaplains, they work together to address the needs of the client with serious and chronic illnesses. So palliative care consultants are provided in a large number of hospitals. This information can be found in your Med-Surg book on page 139. So again, when you turn to 139, what does that give us an example of? The same thing that's what? On the chart. And what is that? What's on the chart? The difference between what? The difference between the two. Oh, my fundamental. Do y'all see it on page 139? Okay, so just kind of familiarize yourself with that information. I'm sure you will see it again. So let's talk about some of the changes that the individual goes through during death and dying. Periods of apnea. When that individual starts experiencing apnea, what is that term called? Cheyne-Stokes respirations. And they'll have a period of apnea alternating with periods of what? Rapid breathing. That's also common. Usually, death occurs when those respirations, when that individual starts experiencing Cheyne-Stokes, death is not usually far away or far off. As the patient's level of consciousness decreases, he or she may lose the ability to do what? Speak, talk to you. You want to teach the family caregivers to watch closely for objective signs. Like what? What are some of those objective signs that they may see in an individual who may be nearing death? Loss of elimination, grimacing. What about restlessness? Do they get restless? Do they moan or groan? Make some facial grimaces? You want to teach them how to perform interventions that can help relieve discomfort and stress as described by the patient family education. So in your book on page 140, there are some things that you can teach the family members to do. And those are called what? Comfort measures. What are some examples of those comfort measures? Coolness of the extremities. What can you do for that? Cover them with a blanket. Increase sleeping. What are you going to do for that? Spend time with them. Fluid and food decrease. But offer small what? Sips. Incontinence. What are you going to do? Keep them clean and dry. So be familiar with those comfort measures. Again, those are on page 140 in your book. You want to assess for signs and symptoms of distress, including intensity, how intense it is, the frequency, how often it's occurring, the duration, how long it lasts, the quality, and exacerbation, when it's getting worse. So let's talk about psychosocial assessment. People facing death, could they have fear or anxiety about the death or impending death? They may have some difficulty coping. I don't want to imagine that, but I would imagine it could be very stressful. What do you all think? You want to assess any cultural considerations? Could an individual have some cultural considerations as they're nearing death? Yes, they can, and we're going to discuss some of those in a moment. You want to assess any values, religious beliefs that the patient and the family may have that could influence their dying experience. Who can give me an example of something that someone may have done as they're nearing death? Their last rites? Open a window? Okay, I hear after they die. What else could they do? Request their chaplain or pastor or minister or preacher to come? What else? Patient-centered and cultural spiritual considerations. In some cultures, families may not want to know about the terminal condition or illness of their loved one. Can y'all think of any particular situations where somebody said, we don't want to know? Or the patient may not what? Want to know. Don't tell me a thing. I made my decision. This is it. Y'all have done enough. I'm tired of all of this stuff hanging on me. I'm tired of being in the hospital. At the end of life, adults may feel challenged about their spirituality or want spirituality to become a bigger part of their life. Can you see some people drawing closer to their spiritual component? Asking to see the chaplain, wanting to be prayed for, right? So let's talk about our next slide in terms of what we're going to be doing or our role. Who's familiar with these? Have y'all seen these before? When did y'all last see them? There used to be a sign in this room. Y'all remember last semester y'all had a big green sign? What are these things called? Clinical judgment management model. So let's talk about them. Assessment and recognizing cues. What are some common emotional signs that we might see in an individual? Sadness, anger, fear. I hear denial. What are all of those things, most of those things related to? There's a person called Kubler-Ross. And what is Kubler-Ross known for? Stages of grief. You have a PowerPoint in your Canvas module. You'll need to be familiar with those, okay? Because you will see it again, I'm sure. So let's talk about analysis. We're going to analyze cues and prioritize hypotheses. So when we analyze cues, we're going to be looking for symptoms of distress that will prevent them from having a peaceful death. Should that individual be able to die at peace? So distress, what will we do to promote comfort for a patient who's in distress? What might be some of those interventions? Pain management. What else? Positioning to keep them comfort. Anything else? Alternative and complementary therapy, so aromatherapy, maybe a little light massage, right? Music, very good. Managing the symptoms of distress. The most common end-of-life symptoms that cause a patient to have distress include what? What's number one? Pain. Have you guys ever experienced pain before? What do y'all know about pain if it's not managed? What happens to you? It affects everyone. Do you get irritable? Do you get fussy? Do you get cranky? Do you get sharp with people? Does it interfere with your sleep? Yeah, it can make you a bad person, right? What about weakness? With this individual who's nearing death or end of life, or do we expect them to experience weakness? Yes, especially if they're not taking or consuming anything right, or the progression of their disease or illness. What about breathlessness or dyspnea? Might it get hard for them to breathe? Nausea and vomiting. Is that a common symptom? Yes. Agitation and delirium. What do we know about that? Do they get delirious? Could they start fighting you? Think of if it was cancer or something that's affecting their cognition, right? Could they get disoriented? Possibly. What about seizures? That's also possible. Planning and implementation is where you're going to generate solutions and you're going to do what? Take action. And in this section, action for you is doing what? Nursing what? Interventions. Interventions is where you, the nurse, you're what? Doing something. Last but not least is evaluation. And what do we do in the evaluation part? We evaluate. We take a step back, look at what we've done, if it worked, if it didn't work. And if it didn't work, what do? I'm glad y'all said that. Say it again. If it didn't work, we do what? And I'm only saying that because it wasn't long ago I did a remediation class, and I was shocked, literally knocked off my feet. We're halfway into the semester, and students said, I've been doing what I've been doing. And I'm saying, is it working? Well, no, it hadn't worked. But do you want to do something different? No. I want to keep doing what I'm doing. It worked for me last time. So what's the part? I hope the light bulb is coming on for some of you all. I was blown off my feet, literally. If it's not working, what do? We change something up. We do something about it. We intervene. So let's talk about assessment where we recognize cues. In the assessment phase, what are we looking at? Are we looking at the patient's diagnosis? What about their past medical history? Every patient you've taken care of, when you got into that chart, did you see the past medical history? What about their recent state of health? We're going to identify symptoms of distress at the end of life. Whatever that could be causing them distress, we're going to identify those. Let's talk about our physical assessment, the signs and symptoms. Level of consciousness often declines to lethargy, unresponsiveness, and then that individual could possibly go into a what? Coma. Cardiovascular dysfunctions lead to a decrease in peripheral circulation, poor tissue perfusion, and if you touch them, their extremities may be what? Cold, mottled, or even what? Cyanotic, right? Their blood pressure is going to decrease. Often it is only what? Palpable. Usually you can't even get it. You feel you can't even get it. The dying person's heart rate may increase. It might even become irregular. Gradually it's going to decrease before it eventually does what? Stop. Changes in their breathing pattern is common. And what did we say happened to their breathing patterns earlier? Change stops. Other patients who do not believe in an afterlife may still experience hope for a cure or a comfortable death. Look at your med-surg book on page 140, and there's an acronym for hope. Who can tell me what the H stands for? Sources of hope and strength. What about the O? Organized religion and the role that it plays in the patient's life. What about the P? Rituals and practices. What about the E? Very good. Families of patients near death often manage or manifest symptoms of fear. Do the family members get anxious? Do they get nervous? They may have a knowledge deficit regarding the process of death and their role in providing care. What do I do? What's going to happen next? Ask them if they want to do what? How can we be supportive to this family member? Listen and do what? Explain and offer what? Resources, support, encouragement, bereavement counseling. Do you want to talk to the clergy? Do you want to talk to the chaplain? What if it's a young individual that was like in a motor vehicle? A young, healthy individual. What kind of discussion might we have with that family? Organ donation. I can remember, y'all, and we had never considered this. My family and I had never talked about it. But my mom was 46 when she passed, and she was a healthy woman. I'll never forget when they came to talk to us about organ donation. Not on any medication. And at first it was kind of offensive. We felt offended because she's dying. But then understanding she's brain dead. So we made a decision as a family for my mom's body parts to go towards organ donation. So, I have some forms up here on more that I'm going to pass out a little later. But could your dying loved one be life to someone else? And my dad made a comment. He said, well, if it wasn't for that person who had an accident in Canada, I may not have survived. He broke his C3, 4, and 5, left him partially paralyzed. Him and a friend was driving to Canada, going hunting. Friend fell asleep. They had a terrible MVA, but somebody had died, and he needed some whatever to go in his neck. So, it just made us more open as a family to being an organ donor. How else can we donate among the living? What do we do now if we want to be an organ donor? Do what? You can sign up now. Where do you sign up at? And somewhere else. On your driver's license. What's on your driver's license? It's a little hard. Yeah. So can you have that conversation with the family member? Should you be having that conversation?
Can the family override that?
They have a right to refuse. Yes. Yes, the family has the last say so. It's you acknowledging it's something you want to partake in.
If you sign up on donatelife.org, it is a legally binding document, and your family cannot override that.
I was about to ask you, what does that will?
Okay. Well, I was thinking she was meaning initially, can they override them asking if you want to donate, not thinking that the family member was already a donor. But no, once you put that information on there, you're legal. That's a legal document.
What about on the driver's license?
It's a legal document. It serves as a legal document. Yep. So I don't know anybody who's went to court. Y'all may have some answers on that. But know that anything that's a legal document, it's a legal document. So, having those tough discussions, all right? So let's look at analyzing cues and prioritizing hypotheses. The priority collaborative problem for a patient near ending life are for potential signs and symptoms of distress that will prevent a peaceful death. So analyzing cues and prioritizing hypotheses, what kind of conversation do we want to have with the family? If we're preventing distress and trying to keep them comfortable, what are we asking them about? Giving what? Well, we're talking about for the patient, though. If you're going to be trying to keep this patient comfortable, preventing a painful death, pain management, comfort measures, right? One of those tough decisions. Which brings me to this next question. If you're uncomfortable with death, should you be going into hospice and palliative care? So an individual, before they jump into this field, what do they need to do? Shadow someone and evaluate yourself, right? If you got a problem with this, it's probably not the place for you. There are other fields that you can jump in related to health care. Let's look at planning and implementation. And we always say that planning and implementing is for you, the nurse, is doing what? Doing things. All right. What could you do for that mom who had a stillborn infant? Let her spend time with the infant. Take pictures. Yeah, they give you those pictures. They give you a memory kit, Gregory. And inside of it, it could be a little locket of the infant's hair. It could be footprints or the handprints.
They have little bears that are the same weight as the baby.
That goes in some of them now. Yeah, what else can we do for this mom? And this information is in your OB book. And the chapter of it is around page 814 is the care plan. And it goes to like 820. What else are we going to offer that mom?
After she has people that like she would like to be there, like support.
Call in people. What else? I'm going to tell you something that many of you may not have known. But did you know some of the funeral homes provide a burial cradle free of charge sometimes for the infant? I can remember working on OB, and every time we had a fetal demise, it seems like I got that patient. But I would call the local funeral homes, and they never had one. It was like, oh, we out. But some of the funeral homes do offer a cradle, a burial cradle. Do we need to talk about the funeral arrangements? And what terms? What kind of conversation are we having? Do you want to dispose of the body? Or would you like the hospital to dispose of the body? That family member takes the body home with them. The funeral home don't come pick up a fetal demise, okay? Yeah. Family takes the body home with them. Are you going to allow them to spend time with that infant? Yes. I can remember going to the morgue like 3 times. I'm like, okay, I can't do this no more. Supervisor, can you go to the morgue? But it's as much time as they need, okay? Allow time for them to express their emotions. And sometimes that could be negative emotions. It could be a lot of anger, right? Y'all are looking shocked. A urn.
And she held it in the bed with her, like it was her baby, like she was holding the baby. She was not coping well with it at all. We were very worried about her. Yes. Very scary.
Raven?
My sister went through this, we did as a family, to educate them that, the time process and the changes that will happen to infants.
Okay.
As far as like the skin changing,
Mm-hmm.
we can.
Tell them
there's a time
expected
limit.
findings. What's going to happen?
Yeah, there's a time limit that we have to take them back, put them back in the pool room, just to prevent like quick decomposition. So, I mean, you have time with the baby, but you don't a lot, especially like the sooner they're born, which my niece is 26 weeks.
What's different with the adults?
Don't take them home.
You don't take them home. I agree. But what about time to stay with them? Is there so much as a time limit on them? No, not really. We allow them to spend time with that adult. We're not kind of rushing them, giving them time to do their rituals or whatever it is. But we do post-mortem care. And we're going to go over that toward the end of the lecture. There are some things that we're going to do as our role. What kind of conversations are you having with them? In general. And we can be baby, adult. What are we saying?
What funeral home they were going to use, where they were going to.
Okay, we could ask about the funeral home. We could notify them. Do what now? Ask them about the death certificate. Usually the coroner, the funeral home takes care of all of that. What were you saying, Jasmine? Okay, we can make calls. We're here for you if you need us to call someone. What else? What are some things not to say? Well, you know, you got 2 more babies at home. You know, losing this one, you fine. At least you got 2. Some women don't even have 2. Do we have those kind of conversations? Okay, you have some things to avoid saying and things you can say that's listed in your book. Yeah. We've had full-term infants to go. Yep. And I'm going to say this, different rituals, we sign a release. That body goes home with them. We don't do any investigation or any of that, but some cultures do some different things when they get the body to their residence. The hospital will dispose of it, and I can't tell you what that disposal is. I don't know.
I'm saying, what if they take it home and they don't take the body to the
We don't have nothing to do with when you leave the hospital. That's in your possession, okay? Listen at this, y'all. Listen up. Okay? We got here at St. Dominic, they call it a funeral home, and they come pick it up. When I was last an employee at Anderson, they took the fetus home with them.
All right, quick.
If you were with a certain a funeral home, yeah. If you are with a certain funeral home, yeah. But if the funeral home comes, know this is a charge. You know.
So like, if you take the baby home, like say we take the baby home, y'all, like, it's illegal for like to have a family member die and you bury them yourself, right? Nowadays, you can't do that. You could in the 1800s, but you can't. You know, like we can't just go out and bury mama in the backyard. Yeah, but you still have to go through the state.
You're supposed to go through the state that there has been a death. You're supposed to. But know that the hospital has no legal ties with you or your infant when they leave.
So like if you don't tie him, if you don't, I guess the baby don't have social security number and all that, so you don't have to go through this. I mean, you don't go
You're
through the
supposed
state
to notify the funeral home. I can't tell you the entire process. And they are to come out and dig a grave and have a proper burial. Yep. Yep, it can happen in a day. So, what are some things you can say? I'm sad for you. How are you doing with all of this? This must be hard for you. I am here for you. I understand your fear. You have a chart with things in there to say. So be cognizant of what you're saying, okay? Did you all know that a large percentage of Americans want to die at home? It's not uncommon. So in your OB book, what to say is on page 817. Okay? So let's move on. When we talk about comfort, comfort should be provided around the clock. In terms of managing pain, what medications might they be receiving or the nurse may be administering? Opioid and non-opioid analgesics. Short non-opioids such as acetaminophen or opioids such as morphine sulfate, oxycodone, hydromorphone. Elixirs can be given sublingually. They may also be given rectally if the patient are receptive to this route. Care of the older adult. Pain in older adults often goes underreported and undertreated. Nurses, you do not withhold drugs from older adults at the end of life. You know, there's a lot of controversy going on right now about giving the morphine, and what is that? Hastening someone's death, speeding up the process. But in palliative care, nurses, you do not withhold the medication from the adult, okay? For patients with known renal failure, fentanyl should be ideally used from the start of an opioid administration. The use of medical marijuana, cannabinoid-based medicines, is increasing in palliative and end-of-life care. Any questions on that? When we talk about complementary therapies, non-pharmacological interventions are often integrated for pain management. We mentioned massage, but just know that it should not be over the site of tissue damage if they have some type of wound or going through radiation. Latoya mentioned music therapy. I think I heard aromatherapy. Managing weakness. So what can we help with weakness? What can we provide them with if they're at home? Mechanical or an electrical bed. What else could we do if they're incontinent? Foley catheter. Weakness combined with decreased neurological function may interfere with their ability to swallow. So they may have some dysphagia. You want to inform families that giving fluid actually increase discomfort. Giving them fluids actually increase their discomfort and in a person with multi-system slowdown. Most experts believe that dehydration in the last hours of life does not cause distress, and it may stimulate endorphin release that will promote their sense of well-being. So, managing breathlessness and dyspnea. What are you going to do for the individual with dyspnea? This is going to be shocking. Pharmacological intervention should begin early in the course of dyspnea. Non-pharmacological interventions are used in conjunction, but not in place of drug therapy. Opioids such as morphine sulfate are the standard treatment for dyspnea near death. So I noticed y'all said set them up, give them a little oxygen. They work by, this is that opioid, altering the perception of air hunger, reducing anxiety associated with oxygen consumption, reducing pulmonary congestion. Patients who have not been receiving opioids will likely start on a lower dose of oral morphine, and they're going to give it to them what? Every 4 hours. Those who are taking morphine or other opioid or pain medicines may have a higher dose if they're breathless. If a patient is having severe respiratory distress and poor oxygenation, morphine by mouth may be needed and repeated as often as every 30 minutes. Oxygen therapy for dyspnea near death has not been established as a standard of care for all patients. Coming straight from your book. Let's talk about bronchodilators. Who might receive albuterol inhalers or nebulizers? Those with bronchial spasms, when you hear wheezes. Corticosteroids such as prednisone can be given for bronchial spasms. Anticholinergics, atropine, may be administered to do what? If we give that, dry up those secretions. Oropharyngeal suctioning is not recommended for loud secretions in the bronchi or the oropharynx because it is not often effective. So should you be suctioning in back? Let me get that out. Oh, it's just rattling. Should you be suctioning them? Other non-pharmacological interventions. Limiting exertion. Do we want them to overexert themselves and wear them out? Inserting a long-term urinary Foley catheter to avoid dyspnea. Position the patient with the head of the bed up or either in a hospital bed or a reclining chair. Applying wet cloths to their face. Can we put a wet bath cloth on their face? Encouraging imagery and deep breathing. Take some deep breaths. How are we going to manage nausea and vomiting? Although it's not as common as pain and dyspnea, Nausea and vomiting often occur, and it can go on within the last week. It is particularly common in those with HIV and AIDS, breast, stomach, and other types of cancers. So it mentions some causes of it, but it doesn't say an actual intervention. What about constipation? If they're constipated, is a cause of nausea and vomiting, you can give them a what? Fleet enema. If stool in the rectum cannot be evacuated, you may give them a what? Mineral oil enema. Nausea and vomiting related to other causes can be controlled by antiemetics. And what would some of those be? You got 3 or 4 of them there. So let's talk about some of those aromatherapy interventions. What are some of those things we could use? Where are my holistic people at? Chamomile, what else? Camphor, fennel, lavender, peppermint, and rose. Reduce or relieve vomiting. Sometimes these aromas can do what to vomiting? Make it worse. Managing agitation and delirium. First, you got to assess for pain or urinary retention, constipation, or another reversible cause. Delirium is an acute fluctuating change in mental status accompanied by inattention, disorganized thinking, or an altered level of consciousness. When delirium occurs in a week or 2 before death, it's referred to as what? Terminal delirium. We're going to take a pause right here, and then we'll jump back on it. You guys can have a 10-minute break. Therapy is one of the complementary therapies. It can produce relaxation by what? Quietening the mind. How many of you use music therapy at home? I see a show of hands. Managing seizures. Seizures are not common at the end of life, but they can occur. So around-the-clock drug therapy may be needed to maintain stability for those who have a high seizure threshold. Managing refractory symptoms of distress. So opioids for pain or dyspnea and other drugs such as antiemetics and anti-anxiety agents can be given. Meeting these psychosocial needs. Unexpected death, particularly those in young people, tend to be the most traumatic. Would y'all agree? When a person has a chronic life-threatening disease, he or she or the family may have some knowledge about the expected outcome. And also they have time to kind of what? Process it and go through those stages. You know? Whereas death is termination of life, dying is a process. People facing death may demonstrate emotional signs and symptoms to their response of the dying process. So assisting the patients with the grieving process, that's in your book on page 145. Mourning is an outward social expression of loss. What have you all seen? Have you all taken care of anyone who died or was going through the dying process? What have you seen from a family member's perception of how they dealt with it?
Her daughter was there with her from out of town, and I just kind of sat out in the corner while she played her favorite song, and she used to lead in church song, and she sat there as long as she could, but I could tell she was kind of, because of the breathing, she was familiar with Chinese culture, and once the mama started sounding funny, she was like, I can't do it, so she kind of teared up, I hugged her, and she left out, and like an hour later, we had the house came.
So being therapeutic, just being there, like Latoya said, maybe playing some music for your loved one. What else?
I had a family member that it was a sudden death. She would just talk to the mom and walk out for the bath and cut it, and died. And when I was waiting for the doctor to come around, I already knew, but we moved to to the door, she already knew, and she actually pulled me down the floor with her.
Mm.
Because she was so, she just like.
Distraught.
She just fainted, like, basically, and, it was very hard for her, the whole thing, it was unexpected.
Unexpected deaths can be very hard. Anybody else care to share what you experienced with the patient? I'll never forget my first patient out of nursing school at Anderson South as a nursing student. Died on me, my first patient. My very first patient. That was traumatic to me. Yeah, at the same time. But I pulled through it, and I'm going to say, luckily for me, he was there alone. That individual had been in the hospital for quite some time. But it was sad. Jimmy?
I'm just gonna say, those other nurses that are experienced did you dirty.
Well, I was a new student, so I was in the program. I was in the program, yeah. They should have told the nursing instructor. Or was it the nursing instructor? I don't know.
Oh, wait, one time the name of our nursing instructor was like, hey, there was someone that died like 2 hours ago. I was like,
Okay. So we want to accept whatever the grieving person says about the situation. Sometimes there can be a lot of anger. Can be displayed. So we can suggest that the patient and the family record stories or print videos. Bereavement group. Who could benefit from a bereavement group? Which family members? What would be an example of situations where someone could benefit from a bereavement group? Parents, mothers, daughters, spouses. I think about, would you say that's somebody who, I think of more traumatic events in terms of a bereavement group than somebody who's had this long outdrawn illness. Not saying they couldn't, but who would it be most beneficial to? That individual who's had a recent traumatic, sudden death or loss, okay? When assessing the spiritual needs of a dying person or patient, consider their end-of-life preferences. Are there some patients who say, that's it, kaputty, just leave me alone, I just want to lay here? You want to consider their preferences. Certain tribal ceremonies may take place. Have y'all witnessed or seen any tribal ceremonies? Of what?
a shaman.
Shaman? Have you seen anything?
My sister told us about one that she experienced when she graduated.
I can remember working at Anderson, and we would have a lot of the Native American population. And whenever they lose someone, it would take about 20 minutes in a room. We weren't in the room, but it was a lot of them in there, and there was chanting, but it would take them about 20 to 30 minutes inside the room. Such statements such as everything happens for the best, God sends us only as much as we could bear. These are not helpful when a person has yet to express their anguish or their anger, okay? So we're going to do what? Avoid making statements like that. Although emotionally challenging, sometimes witnessing the death of a loved one may facilitate the family's acceptance of the death. As hard as it may be, but witnessing the death may help with acceptance, okay? So let's look at some common emotional signs of approaching death. These can be found in your med-surg book on page 141. Withdrawal or letting go. Vision-like experiences. How many of you have seen an individual where they're like reaching at something? Or said, did you see that? It was an angel. Yeah, my mama sitting over there. Seeing their grandparents. Seeing somebody who's already deceased. Saying goodbye. How many of you have witnessed family members telling them it's okay? We're going to be okay. We're all here. It's okay. We know you're hurting or you're tired.
Seems like some of them hold on to their
last child show up in the room. Yeah, I can agree with you on that. So, evaluation of outcomes, and again, this is where we take a deep look at what we've done and decide whether or not it worked. So we're going to evaluate the care of the patient. Have their needs and preferences been met? So did you meet the patient's need? Did you promote a peaceful death? Did you meet their preferences in terms of spirituality or comfort? Have control or management symptoms of distress? Did you manage those symptoms of distress? Did you keep them from grimacing and groaning and being restless? Experience meaningful interactions with the family and the loved ones. How involved were you? How supportive were you? What did you offer the family? Experience a peaceful death, and that's the goal for that individual, okay? We're going to look at postmortem care next. And this is in your med-surg book on page 147. But it's also in Potter and Perry too. I think Potter and Perry is a little longer. I want you to look at both. But I want you to be familiar with both. Let me just say that. Because there's some things in Potter and Perry that's not in the med-surg, all right? If the death was at home and expected, who do we call? The coroner. Should we call 911? If the person was in a hospice program, who do you call? You call the hospice. Otherwise, the nurse or the primary health care provider performs a pronouncement and completes a death certificate. Most states allow for the nurse to pronounce death in nursing homes and other long-term care facilities, but only a few states permit that to go on in acute care settings, okay? So pronouncement of death is in your book on 147 as well. After the patient has died, we're going to ask the family members and caregivers if they would what? Like to spend a little time with the patient. So pronouncement of death is on 147 and post-mortem care. Some family members may find it therapeutic to do what to the client? Clean them up. Give them a bath. Comb their hair. Yeah. Prepare the body for the funeral home to pick up. Before preparing the body for transfer, we want to ask the primary health care provider whether or not an autopsy is required, okay? When death is expected, an autopsy is not likely. However, you do want to confirm that. You want to be aware of religious preferences. And one, for example, that do not allow autopsies is who? Orthodox Judaism. Okay, so let's look at our book on postmortem care. We're going to hold off. I think I got a PowerPoint with it in there coming up. Yeah. So evaluations of outcomes. What would you diagnose this person with? If you had to put a diagnosis to the family member, what diagnosis would you give the family member? What are they going to start doing right now? They've lost some grief. They've lost someone. So grief. Physician-assisted death, sometimes referred to as assisting in dying, or physician-assisted suicide, is gaining the worldwide public support. So there's a lot of controversial issues out there about that. Again, remember, withdrawing or withholding life-sustaining therapy, formerly called passive euthanasia, involves discontinuing one or more therapies that might prolong the life of a person. So another phrase used is letting the person die naturally or allowing natural death. An alternative method for hastening death is called voluntarily stopping of eating or drinking. Have you seen some patients who just refuse? They'll bite their lip, put their lips together so hard and won't take anything. Nurses are usually the best and most immediate position to discuss all of these issues. So guess what? Tag, you're it. You're it. Yeah, when you walk in, you didn't know what you was walking into, but welcome to nursing. So physical signs indicating that death has occurred. What's going to happen? Stop breathing. Heart stop. Pupils are going to get fixed and dilated. Pale and waxing. Temperature's going to drop. What's going to happen to those muscles? They're relaxed. So is it uncommon for them to have a number 1 or number 2? It's not. Their jaw may do what? Fall open. Let's look at pronouncement of death. What do we want to make certain of? The time. What else? You want to make sure that they're dead. Yeah. Because there have been some weird instances where patients have made it to the nursing home to the morgue and woke up or riding in the hearse and woke up. So you want to make certain they're deceased. Should we identify the patient and make sure that they have on an ID badge or tag? Toe tag. Assert that the patient does not what? Rouse to what? Verbal and tactile stimuli. Auscultate the absence of heart sounds. Palpate. Look, listen for the absence of spontaneous respirations. Document the pronouncement. If your state and agency policy allows an RN to pronounce the death, documents as indicated on the certificate. So when you look on the next one, it's a little more information. Let's read number 1, someone. Okay, keep going for me. Read a few if you don't mind.
Ask the family and significant others if they wish to help wash the patient or come with them for care, respect and follow the cultural practices for body preparation. If no autopsy is planned, remove or cut all tubes and lines according to agency policy. Close the patient's eyes unless the cultural or religious practices for a family member or other person to close the eyes. Insert dentures if the patient wore them. Straighten the patient and lower the bed to a flat position. Place a pillow under the patient's head. Wash the patient as needed and comb and arrange the patient's hair unless the family desires to perform bathing and body preparation. Place waterproof pads under the patient's hips and around the perineum to absorb any excrement. Clean the patient's room or unit. Allow the family or significant others to see the patient in private and to perform any religious or cultural functions they wish. Assess that all who need to see the patient have done so before transferring to the funeral home or morgue. Notify the hospital chaplain or appropriate religious leaders if requested by the family or significant others. Ensure that the nurse or physician has completed and signed the death certificate and prepare the patient for transfer to either a morgue or a funeral home. Wrap the patient in a shroud and attach identification tags for contingency policy.
Okay, now I'm looking for the information in Potter and Perry. There's a chart in Potter and Perry too. Anybody got the chart or the page number? Potter and Perry, 802, 803, caring for the body after death. 802, 803. Be sure to read over that as well. 802, 803. Y'all see that? There is something different. One of these books, they raise the head of the bed about 15 to 20 degrees. death. Let's look here. Okay. Straight or the side of the bed, care of the body. So care of the body after death is on page 802. And I want y'all to read over it. So look at number 6 on page 802. This is where it's a little different. Elevate the head of the bed is what? After death to prevent what? Uh-huh. So, again, I'm going to ask that you read over both of these and be familiar with the information on both. It's a little different, all right? Any questions on that? All right. It's similar. Right, it's similar. The information is similar. I just want you to be familiar with both of them. So, coming up, we got a little video. I'm going to stop the recording, and we're going to play these little